Dr. Pradeep, who is a consultant at Shankara Hospital, Shimoga. Yeah. And thank you all for participating so enthusiastically in a morning session and on the last day of the AIOS. Thank you.
Very good morning, one and all. I would like to thank Dr. Divyansh and the moderator for giving me this opportunity. I'll be presenting a case which, because of an obvious mistake, maybe like I ended up in a lot of problems. So it was a 58-year-old gentleman with a blurred vision in left eye since 15 days. He was a known diabetic since 4 years and was on regular therapy. He had a history of fever 6 weeks ago. It was for a 10 days duration. Nasal swab was done and the RT-PCR was positive for COVID-19. Chest X-ray showed bilateral multifocal peripheral patchy ground opacities. He was treated with remdesivir, low molecular weight heparin and dexamethasone oral for 1 month. His best corrected visual acuity in the right eye was 6.9, in the left eye 660. He was pseudophakic. In the right eye, the antechamber was quiet. In the left eye, there were 1 plus cells. So this is the fundus photography of the right eye. Here we can see that there are multifocal retinitis. We can see at multiple areas, we can see the patches of retinitis, and they were predominantly in the perivascular area. So this was the left eye where we can see a dense vitritis, and we can see that there is a peripapillary and macular retinitis. The visibility was poor due to the dense vitritis. So the provisional diagnosis was bilateral retinitis, but the etiology was something that we were looking at. The blood counts were normal. The ESR is 5 mm. The dengue, chikungunya, EBV, IgG, IgM were negative. CMV, HSV, 1, 2, VZV, only IgG was positive, but IgM was negative. Wheel Felix was also negative. So HIV, VDRL, TPHA, Toxo, IgG, IgM were negative. MON2 was more than 15 mm, but HRCT was negative for TB, quantiferon was negative, pulmonology opinion was sought, who told that there was no evidence of pulmonary tuberculosis. Provisional diagnosis of a post-fever, post-viral retinitis with atypical features was considered, and we considered only an oral prednisolone 1 mg per kg, and he was monitored with endocrinologist for his blood sugars. After 3 days, we could see that there was an increase in the size of the retinitis. Though there is a posterior, the central clearing is there, but it's expanding in the edges, and the vitreous haze had increased in the right eye. This is the nasal lesion. Again, here we can see that there is it's growing closer towards the optic disc. In the left eye, we could not make out much difference as such. So in view of worsening, we stopped the steroids and considered provisional diagnosis of non-necrotizing herpetic retinitis. Started on valacyclovir 1 gram 3 times, sent AC tab for PCR. But the PCR was negative for HSV, VZV, CMV, Mycobacterium tuberculosis and Toxoplasma. 3 days post valsariclovir, again there is an increase in vitritis, and in the vitreous actually there is an increase in the retinitis also. It was expanding, it was going close to the fovea, as we can see over here in the right eye. And in the left eye also we could see that this size was increasing, though the close to the optic disc it is somewhat cleared, but at the edges it is increasing. There were vitreous snowball-like opacities in this time. We could see that there were some snowball opacities in a string of pearl-like appearance in both the eyes at this time. We stopped valsariclovir considering the possibility of a fungal retinitis, which is described in the literature. Based on mainly because of the presence of this string of pearls in vitreous, and at that time there were multiple reports of mucormycosis post-COVID. So there was this postulate that they are more predisposed to fungal infections. So that was one more point in favor. Considered a left eye pars plana vitrectomy with intravitreal voriconazole, amphotericin B and vitreous biopsy. There was an inferior iatrogenic break, so in silicone oil tamponade was considered, as we needed a clear media for further assessing the progress of the lesion. The 2 days we even started in oral voriconazole. The vitreous biopsy showed pus cells, but gram stain, KOH mount, bacterial and fungal culture were negative. PCR was negative for COVID. So this was post antifungal 2 days. In the right eye, there is continued expansion of the retinitis in the left eye. In the one which was close to fovea was also showing an increase in retinitis. This was the left eye post surgery. We can see that the retinitis, this was like 12 hours after PPV, and this is 2 days after the commencing the antifungal therapy. So we can see that this edge actually still increased, though posteriorly it was decreasing. In the periphery it continued to increase, and there was a retinal infarct in the inferior half of the macula. So it was like we had already tried antiviral, antifungal. So I just took 2-3 opinions, and everyone suggested there's nothing wrong in giving bacterial, you can just try once, though there's no evidence till now. We are already losing one eye, and the other eye, the lesion is going close to the fovea. So in a desperate attempt, started with left eye intravitreal piperacillin tazobactam and vancomycin, and intravenous vancomycin, piperacillin tazobactam, and doxycycline 100 mg PD. 2 days post antibacterial, the retinitis started fading. We can see that the retinitis was reducing in size. Here it was fading. In the left eye also, like these lesions were slowly regressing, and we continued intravitreal antibiotics every 48 hours in the left eye for 10 days and intravenous antibiotic for 14 days. Doxycycline was continued for 1 month. This is 7 days post antibacterial. We can see that the retinitis is significantly regressed in the right eye. Here we can see, this is a 3-month follow-up. We can see that there is still a persistent retinitis, like persistent whitening. I don't say retinitis, there is persistent whitening, and we can see this hemorrhage around it. We had stopped all therapy like almost 2 months before this, but still this was there. I again thought like, shall I give doxycycline? I consulted and told to just follow up closely every weekly. That's what we thought from here. Left eye, the lesion was completely regressed, and silicone oil removal was planned. This is 8 months follow-up. We were actually seeing every weekly for almost 1 to 2 months, then every 2 weeks, then every monthly. This whitening is still somewhat present even there, and the left eye was not showing any evidence of any activity. So went back into the literature. Like there are 2 reports of endogenous bacterial retinitis, but it was in an immunocompromised patient. And in 2 of those cases, in one case they could not get anything positive, even the biopsy, everything was negative. In one case it was positive. So the questions which remain unsolved are, is it really a bacterial retinitis, or what really worked? I am not sure till now. And whether that persistent whitening is indicative of a dormant infection, should we like do anything to it, or like it's almost 8 months now, just wait.
This is, I think, typical of the rickettsial that we see very often. Of course, wheel felix was negative. The first slide showed that wheel felix was negative. We usually get wheel felix positivity, and we start the patient first thing on doxy.
Doxycycline.
Doxy is something that we think is the panacea for all these post-viral fever retinitis, and it usually works very well. 5th day after starting doxy, we start the patient on oral steroids, and I think you are probably biased by the concurrent, COVID and the mucormycosis that was going on at that time. Otherwise, probably you would have also started on doxy at the first go.
I even start doxycycline for all the cases of post-viral retinitis. I start for every case. This dense vitritis was something which was not very. If we had started at that time, I don't know whether if it has resolved with that alone without doing anything of this. I'm not sure.
The vitritis also is something which
dense vitritis is something which we don't see, and we usually see extensive exudation in the terms, like there will be for the amount of retinitis what we see, the amount of subretinal fluid, intraretinal fluid that we see in post-viral retinitis is disproportionate. We see a lot of edema, subretinal fluid, but this patient did not have, even the OCT we have done through these lesions, there was no fluid or no edema around it. So those are some of the features like which made me think something else than the regular post-viral retinitis, or whatever we consider probably a post-rickettsial one that was not considered initially.
I want to ask everyone if syphilitic retinitis is something that you will consider as a differential diagnosis.
which presents as plaque, but in this I think the
VDRL, TPHA were
both
negative.
So
Had managed 2 cases of necrotizing syphilitic retinitis before this. There was extensive necrosis in the inner retina. That's what we had at that time. Yes, sir. Yes, sir.
Yes.
Both TPHA and VDRL were negative, sir. FA was not perfect.
Both the lesions in the right eye, both nasally and temporally, they are
Yes,
outer retinitis, right? You can see blood vessels going over them. Over this and also the nasal one at all points in time, right?
Yes,
And also in the left eye at the outset, although the media is hazy, but you can see because the vessels close to the disc are more prominent, you can see them going over them. So whatever this lesion was, in both the eyes began as an outer retinitis. Does epidemic retinitis or post-fever retinitis begin as isolated outer retinitis is my question. To my mind, the answer is no. I don't think the doxycycline worked. I don't know what this is, but I don't think this is epidemic or post-fever retinitis. And if you had the OCT scan, I would strongly suggest, to you to go back to it. It will tell you that the outer retina was preferentially involved, neither the choroid nor the inner retina.
Choroid was not involved, sir. That's I definitely remember
The photos
that.
telling you. The photos tell you.
If it is see the infero-nasal retinitis,
No, this is sorry, sir. This one.
yeah.
No, this was an artifact, sir. This was an artifact. Yeah, this was not there. I just.
Yeah, the question which I had is that when your retinitis was worsening,
Yes.
so in post-fever retinitis, when you have retinitis worsening, you don't have the lesions which are actually growing more. More you have is the
New
exudation
lesions.
and the new lesions.
New lesions.
And the subretinal fluid and the intraretinal fluid which you were talking about. So that was not happening in your particular case. So just by, and the location of the retinitis itself. So whatever post-fever retinitis I have seen, they are more closer to the optic nerve, very close to the macular region, rather than having something very far away around the equatorial region. That's something which is unlikely. So so when we talk about epidemic retinitis, we usually use the word posterior pole retinitis. That is how we call it's a posterior pole disease rather than having it at the equator and slightly beyond it. And also the exudation, and that means exudation in terms of subretinal fluid and intraretinal fluid was not happening, especially when your patient was worsening.
I still believe that starting steroids in the beginning without an antibiotic cover was one of the biggest mistake I have done in this case. I still believe that, and maybe I don't remember any case in which I would have started.
Toxo also you would need it probably an AC tap and sending it for PCR.
Send it,
Toxo.
sir.
You sent it for PCR?
AC tap was done for PCR, Toxo was negative, Toxo IgG, IgM were negative.
Yeah, fine.
I have done CD4 count, sir. CD4 count is normal. I mentioned also CD4 count was normal actually. Yes, sir. That was also done, sir. Yes, I have done.
If you made a diagnosis of retinitis, I think one rule of thumb, at least what we were taught by, boss, as I like to call him, if you make a diagnosis of retinitis, it's infective unless proven otherwise. And if you make it, Beckett's being one of the exceptions, and if you make a diagnosis of choroiditis, it's immune unless proven otherwise. So once I think the diagnosis was, whatever be the etiology was retinitis, I think starting on steroids was a little bit of a,
Yes.
we was kind of jumping the gun a little bit.
Dr. Pradeep, what was in that literature review which you showed, what was the causative organism in that endogenous bacterial retinitis which you spoke about?
Sir, actually they could, what they say is the histopathological section showed necrotic retina, and they are not sure about the organism. They say that it was, yeah.
Yeah, so
They say that treatment with antibiotic resulted in improved vision in both the patients. That's what they say. This is also presumed.
And secondly is, why did you choose Tazobactam piperacillin as your antibacterial agent instead of starting with the local one of vancomycin?
Sir, I have to agree that it was at that time I didn't wanted to take a chance. It was done. I didn't wanted to take a chance. Fire it with a I should not be feeling that antibacterial didn't work. So I wanted something which a very broad spectrum and no antibiotic, lesser antibiotic resistance.
I think anybody would do that because you don't want to leave anything to chance. you want to do
at that time
do the
again
best.
trying ceftriaxone, then thinking that okay, maybe like antibiotic resistance, and again shifting, like it was getting too worse already. The patient's daughter was a doctor by herself, and they were very like understanding, but still at that time like shifting to one, it looked crazy to myself, giving antiviral, antifungal, and then antibiotic, like.
Good, at least you didn't start everything together. Other people just mix and give.